Did you get in? Has come up here, they're trying to get into this gate. Look at this. Look at this. I can't believe what I'm witnessing right now. There's tear gas right there. Again. That plume of smoke in the background, I didn't catch it on camera, but that's a petrol station apparently blowing up a gas tank.
Our government is very wrong. Because they kill 20 people yesterday. They are very bad. The KP Salma Wali.
Are you okay?
I'm okay.
Yeah.
Because tear gas affected me in my eyes and
I know. I can see it, my friend. I can feel it, my friend, too. They're firing off tear gas over there as well, again. Look at the sheer amount of people. Again, to the left of me, they're putting down all these railings. They're now trying to get into, I don't know, I believe it must be some government office. All the barbed wire being pulled down. The riot police in there. really gets in the back of your throat, in your eyes. It burns the forehead, and it smells like wasabi or mustard.
So we think of hypertension, which is really common in the U.S. Good afternoon, good morning, good evening, wherever it is, whatever time it is for you. The topic today is going to be hypertensive retinopathy. So when we think of hypertension, which is really common in the U.S., it's almost uncommon to not have it once you hit a certain age. Hypertension, we don't really think of the eyes. We think of the kidneys, we think of the heart, we might think of the peripheral vessels, the coronary vessels, but we don't think of the eyes that much. Nevertheless, you can get problems, or not necessarily problems, but changes in your retinal vasculature, in your retinal and choroidal vasculature, when you have severe hypertension. When I'm talking about severe hypertension, in quotes, I'm referring to either a severe acute case of hypertension, so like a hypertensive crisis, where your blood pressure is above and beyond that 180 over 110 range, or a patient with chronic hypertension. So that would be like your 70-year-old man who's been taking lisinopril for the last 20 years for mild hypertension. So this can be a problem from severe acute hypertension or chronic hypertension, and it does pretty much the same thing to the eyes. Hypertensive retinopathy itself, though, is not reliably symptomatic. You tend to not have visual changes with hypertensive retinopathy itself, but its presence, its pathological presence, is indicative of an underlying problem. So this affects both the retinal and choroidal circulation, and the retinal circulation is more inner, towards the middle of the globe of the eye, and that feeds the inner parts of your retina, and the choroidal circulation feeds the very outer retina, retinal pigment epithelium, and then of course the choroid. The retinal vasculature is autoregulated. So what does that mean, autoregulated? What it means is that when your systemic blood pressure goes up or down, the retinal vasculature can expand or contract to keep the blood pressure in the retinal vasculature at a set range. So it's kind of like a thermostat. Now, when the blood pressure goes too high, specifically if it exceeds 110 to 115 millimeters of mercury, the vasculature can no longer auto-regulate itself. So think about it. When your systemic blood pressure goes up, the response of the retinal vasculature is going to be to expand, because when you expand the vasculature, you decrease the blood pressure, and that's the goal. If the blood pressure, the systemic blood pressure goes up, the retinal vasculature, by auto-regulating, is going to bring it back down to the normal range. And likewise, if your blood pressure goes down, the retinal vasculature is going to constrict to maintain a normal blood pressure range. When your blood pressure goes up high enough, however, the vasculature cannot expand anymore. And at about 110 to 115 millimeters of mercury diastolic, that auto-regulation stops working. It can't auto-regulate anymore past that range. So the retinal vasculature is auto-regulated, and that's important to remember. The choroidal vasculature, on the other hand, is regulated by the sympathetic nervous system, by the central nervous system, just like all of the other vessels in our body. This is primarily seen in older patients, and the reason is because older patients make up the vast overwhelming majority of hypertensive patients. So there's two distinct disease processes, and those are the acute hypertensive retinopathy, and that can be seen in patients of any age due to sudden severe hypertension, generally those hypertensive crises, over 180, over 110. And that can be from many different things: hyperthyroidism, pheochromocytoma, acute aortic dissection, although that would tend to be in an older patient, renal artery stenosis, acute glomerulonephritis, drugs, so things like cocaine, methamphetamines, some of the diet drugs, or a pregnant woman could have preeclampsia and eclampsia. So there's many things that can cause you to have an acute hypertension. But this is acute hypertensive retinopathy is due to a sudden severe hypertension. In contrast, chronic hypertensive retinopathy is seen in older patients. Why? Because older patients tend to have hypertension. And hypertension accelerates the process of atherosclerosis. And as we're going to see when we look at pictures, atherosclerosis is a finding in chronic hypertensive retinopathy, but it's not a finding in acute hypertensive retinopathy. So with atherosclerosis, the retinal arterioles are going to expand and they can compress venules, and that can lead to occlusion. So that can be problematic as well. So go back to thinking about why the vessels might expand or contract. You can imagine that if you have an occlusion in an arteriole, that arteriole is going to expand. Why does it expand? Because it needs to decrease the resistance, because the flap has increased the resistance by decreasing the luminal space. All right. So acute hypertensive retinopathy, this is also referred to in the literature as malignant hypertensive retinopathy. However, since a lot of patients are now becoming aware of malignant tumors, we try to not use that word outside of cancer. So it's acute or malignant hypertensive retinopathy. Acute hypertensive retinopathy is typically seen in patients in a hypertensive crisis, as mentioned. Generally, the blood pressure has to be above 200 over 110 to cause retinopathy. But the important number is that diastolic number. Once you pass 115, there's no autoregulatory mechanisms left in the retinal vasculature, and you can start to see changes. Causes of secondary hypertension include things like hyperthyroidism, pheochromocytoma, preeclampsia, drug abuse, and neoplasia. Elevated blood pressure causes direct damage to the retinal and choroidal vasculature, and that's called fibrinoid necrosis. When you have severe hypertension, you get damage to the smaller vessels. And that can subsequently cause ischemic necrosis. So this can manifest as many things. First off is the cotton wool spots. And cotton wool spots is caused by ischemia to nerve fibers. And that's secondary to the ischemic necrosis from the fibroid deposition, which comes from the hypertension. So what happens here then is you get a decreased axoplasmic flow because the nerve fibers are ischemic, and that decreased axoplasmic flow eventually leads to swelling and then opacification, and that's what those cotton wool spots are. Remember that the nerve fibers are the innermost layer of the retina. They're the ones closest to the ones. If you're thinking about, trying to explain this. If you're thinking, when I say innermost, you're thinking about like a ball, like a basketball. The inner part is the part you don't see, so it's the inner layer, and that's where the nerve fibers are. You also see uniform narrowing of arterioles. Why uniform? Because acute hypertensive retinopathy is not caused from atherosclerosis. Atherosclerosis does not play a role in acute hypertensive retinopathy. So all of the arterioles are going to be narrowed from the hypertensive retinopathy. Now, I imagine you're probably asking, I thought you said that the retinal vasculature expands when the blood pressure goes up. And that's true, it does. But once the blood pressure passes the threshold.
Hello, welcome to my channel and thank you for
remember,
watching.
that autoregulatory mechanism no longer works, And now all of those chemicals,
I hope you like my
epinephrine,
art.
or whatever the cause is,
Currently
that's
drawing
causing the
Naruto.
hypertension, now it can do its direct work and constrict those vessels. And that's what epinephrine and various other chemicals do. Some other things that you can see are hemorrhages, so flame hemorrhages and dot blot hemorrhages. They're a little bit different, but for the most part, you don't really need to worry about that. Flame hemorrhages are necrotic vessels in the nerve fiber layers, and dot blot hemorrhages are necrotic vessels hemorrhaging into the inner retinal layers. You can also see papilledema, and that's caused from leakage from the arterioles that supply the optic disc. So when you have elevated blood pressure, that increases the flow of fluid out of the vessels, and that mechanically causes fluid to flow into the optic disc, and that causes that papilledema, optic nerve swelling. And then there's another thing called Elshing spots, and this is particular for acute hypertensive retinopathy. And Elshing spots are just these little black spots, and this is caused from damage to the retinal pigment epithelium. They're these little black spots that have these surrounding halos, and these are typically associated with acute hypertensive retinopathy, although I'm not sure if they're completely pathognomonic. Okay, so here is a patient with retinopathy, hypertensive retinopathy. So see if you can guess what some of these things are. So there's a cotton wool spot. Cotton wool spots look like clouds. So you can see this.
Hello,
like
if you're watching, welcome to my channel. Currently drawing
These are hard
Naruto.
exudates.
I hope you like my art.
So these are just like yellow flecks. You can see these in hypertensive retinopathy as well. And then you have flame hemorrhages.
And if you do,
Flame
kindly
hemorrhages
subscribe.
look like they're kind of
It helps a
feathered
lot.
out. Whereas when you see the dot blot hemorrhages, I'll show you that in a little bit. Dot blot hemorrhages are more like the name implies, dots and blots. Whereas these are feathered out. They're kind of like finger painting, like you smeared it a little bit. Here's another one. So there's a dot. This is probably a dot blot hemorrhage. And you have some cotton wool spots here, here, and here. And then papilledema. So important when you're looking at optic disc swelling, a good way of knowing that you have optic disc swelling is the fact that you can't really see the margins of the optic disc. So it's swollen and it's kind of confluent with the rest of the retina. You don't have this really distinct border of the optic disc. So this is papilledema here. Okay, now this on the other hand, you can see the optic disc. But there's other things wrong with this. And that's the Elshing spots. So these Elshing spots are damage to the retinal pigment epithelium, and you get these sort of pigmented nodules, and then there's a surrounding halo around it. Okay. So you see them all the way around here. Tortuosity, you can also see, that's pretty non-specific, but that's another feature. This one. So there's optic disc swelling. You could probably say that this is optic disc here, but the margins are a little bit confused here. So you could probably say there's a little bit of optic disc swelling here. I'm not sure if these are cotton wool spots down here. They look kind of puffy. That's why I put a question mark down there. I'm not exactly sure. These are dot blot hemorrhages. Dot blot hemorrhages are typically just these small little pinpoint hemorrhages. And then of course flame hemorrhages, these sort of smeared out looking hemorrhages. And then this is a hard exudate. So what do we do for acute hypertensive retinopathy? we really don't do anything for the retinopathy. What we're more concerned about is the hypertensive crisis. And I talk about that in the cardiology lectures, and probably talked about it to a lesser degree in the endocrinology lectures. But we're more concerned about the hypertensive crisis because that can kill the patient. The eyes, well, a patient doesn't need their eyes to survive. So really, when you're dealing with a patient with hypertensive crisis, you're not worried about the eyes. The way you can diagnose this, if you do want to look at their eyes, is either clinical presentation or an ophthalmoscopic exam, although we're not going to do any significant workup for the patient with acute hypertensive retinopathy as far as the eyes go, because there are other things that tell us, their blood pressure, whether or not they're sweating, and so forth, whether they've used drugs. So the underlying cause should be sought based on the patient's history and other symptoms. The treatment is to manage the underlying cause, and I warn you not to reduce the blood pressure too precipitously because you can worsen the damage. So we want to reduce the blood pressure gradually. Some common complications that come out of acute hypertensive retinopathy is a retinal detachment, and this is due to damage to the retinal tissue, and it's because of the exudations in the choroid and retinal pigment epithelium that can cause some traction in between those two tissues, and if the retinal pigment epithelium becomes compromised, you have a retinal detachment. So you have exudations in the choroid and retinal pigment epithelium, particularly these Elshing spots, and these spots can be a place that the two layers can get traction, and from that, then you can get detachment. You can also get retinal detachment because of the elevated blood pressure leading to fluid moving out of the vessels and into the tissue. That can cause an exudative retinal detachment. So various ways you can get retinal detachment. Acute change in vision, usually peripheral, photopsia, those flashing lights, and a new onset of floaters would be consistent with retinal detachment.
I hope
Optic
it's not
neuropathy
blare.
is caused from ischemia of the optic nerve head due to vasoconstriction.
The camera kind of
And with
blares
optic
out.
neuropathy,
Let me
those
know
people have
if
a
it's
clear
blare
disc
at your end,
margin,
please.
papilledema, and flame hemorrhages. But remember, with optic neuropathy, you'll also have problems with vision, problems with moving your eyes. A lot of times with optic neuropathy, moving the eyes is painful. So when you do that visual field test, or you tell them to follow your hand, they may have some pain in moving their eyes in certain directions. So that would be a sign of optic neuropathy. Chronic hypertensive retinopathy is the one we see more often, and chronic hypertension accelerates the development of atherosclerosis, and it's atherosclerosis that's really the problem here. So they kind of are partners in crime. Hypertension is what you get first, the primary hypertension, and then the atherosclerosis comes in with that, because hypertension leads to atherosclerosis. Not the only thing, but one thing that really helps you develop atherosclerosis is the atherosclerosis that's really problematic in chronic hypertensive retinopathy. In the very far advanced form of chronic hypertensive retinopathy, you can start to get loss of acuity. Atherosclerosis reduces the radius of the arterioles, and so the vasculature has to expand to downregulate the resistance. We kind of talked about that earlier. Another thing, though, that is worth remembering is that the arteries, arterioles, and the venules, they travel together. I don't think they travel together in any kind of sheath, but they travel together. And when the arterioles, you know what, I think they do travel in a sheath. Don't quote me on that. But either way, when the arterioles expand, they can compress the venules. And when you get atherosclerosis, the arterioles have to expand to reduce resistance and allow blood to reach the rest of the retina. And so by getting arterial expansion, you can get compression of the venules, and when the veins are compressed, essentially what you now have is a brain retinal venous occlusion, a VRVO. And so that can lead to, that's a big complication of chronic hypertensive retinopathy. So what are the manifestations of chronic hypertensive retinopathy? Focal to uniform narrowing of the arterioles. The narrowing is going to be specifically seen at regions of plaque. However, as this develops over time, it's going to become more focal, but it doesn't have to be focal. Another thing that you see, which is a hallmark finding of chronic hypertensive retinopathy, is AV nicking and AV crossing. And it's the AV crossing that's a little bit easier to see when you're looking at a patient's retina. And so this is caused from arterial compression on venules, and it's exactly what it sounds. The artery will cross over the vein. I'll show you a picture of that. You can also get plain hemorrhages and dot blot hemorrhages due to fibrinoid necrosis. You can get what's called copper wiring or silver wiring. They're different, but this is directly from the atherosclerosis. This is just what you're seeing here.
Hello guys, thank you for the likes.
Vascular lumen due to
And thank you for the
atherosclerosis. And finally,
subscriptions.
you can see a macular star. That's
It really
caused
helps a
from
lot.
exudation around the macula, and this is more in the severe cases. Okay, so what was I talking about here? This is an AV crossing. So here you have one right here. See, these in a normal patient, you shouldn't have this. You shouldn't have these vessels crossing over one another. And you see another one here, and you see another one here and here. So there's AV crossing. That's a sign of chronic hypertensive retinopathy. This is copper wiring here. So you may want to pause it after I'm done explaining this, and then bring it up to full screen so you can see it better. But if you look at this vessel compared to the vessel next to it, you see here is this little line, this sort of copper-colored line that is traveling through what appears to be the middle of the artery. And that is what's known as copper wiring. And this is just, what you're directly looking at is the narrowed lumen due to atherosclerosis. This is copper wiring. You can also see it on this artery here. You see it on this artery down here. See it down here, here. So copper wiring. So here is an example of AV crossing here.
Hello Carolina.
This is the best example, but AV nicking is where you get an indentation on the venule from the compression. So if you have AV crossing, that's good enough. AV nicking is a little bit harder to see. And then here's copper wiring.
Carolina, no entiendo portugués. ¿Puedes hablar español?
And then this here is silver wiring. Silver wiring is a more severe occlusion and up to 100% occlusion, and at that point then it becomes totally necrotic and starts to turn white, and so that's why it's silver. Silver white.
Carolina, no entiendo.
So what do we have here? Try to point out the problems here. What should pause it? Okay, so we have, of course, a cotton wool spot. They look like clouds. Certainly have copper wiring right here. These little lines going through the arteries. Here, here they kind of look like midlines on the road. And you have AV nicking and crossing.
Carolina.
Here's my better picture of AV nicking. So you see here how there's that little indentation in the right here. That's AV crossing.
Carolina, es que no entiendo portugués, pero a ver,
But if you see this
voy a
copper,
tomar
or
foto de lo
especially
que
silver wiring,
escribiste
you see
y luego
that's
lo veo
along
lo
with a
que
consistent
significa
patient
por
history,
Google, por
you
una
essentially
traducción,
make
algo, no sé.
diagnosis of
¿Entendiste? Y gracias por las palabras.
Okay, so this is the macular star. And all this is just exudations around the macula. Remember, the macula is very highly vascularized. So any place where you're highly vascularized, when you have hypertension, you're highly likely to get exudation, transudation out of the vessels. All right, what is this stuff here? Okay, so here you got blue, this is the cotton wool spot. The green here is pointing to the macular star, and the white is pointing to a dot blot hemorrhage. And these hemorrhages have an affinity for the macular
Sí, es Naruto.
A lot of times you see these in the macular area. And I didn't actually point it out here, but this is copper wiring right here. And
Gracias por seguir mi canal.
that AV crossing. So if you know this stuff, you are going to be set for USMLE. They don't touch on ophthalmology a whole lot, and what they do touch on is the basics. But if you know this, you know more than 95% of general practitioners that are practicing right now as far as hypertensive retinopathy goes. So what do we do for chronic hypertensive retinopathy? Well, first off, we need to keep in mind this patient population. So patients with chronic hypertensive retinopathy, just by the fact that they have chronic hypertensive retinopathy, that it's gotten that bad, they are categorically at a 7 times risk for stroke, a 4 times risk for MI, a 3 times risk for coronary artery disease, and a double risk for peripheral artery disease. They also have an increased risk of age-related macular degeneration. Risk factors, in addition to age, which is really the big one, blacks tend to have a more of a likelihood to develop this than whites. Also your family history, smoking, obesity, stress, sedentary lifestyle, excessive alcohol consumption. What we do for this is we treat the hypertension. Common complications out of chronic hypertensive retinopathy are retinal vein occlusion, and that's exactly due to the AV nicking occlusion. This, if it's severe enough, will lead to visual field deficits. Retinal detachment, this is due to vascular fibrosis, and that's the cause of tractional retinal detachment. Optic nerve atrophy can happen from if you have a chronically swelled optic disc. What I'm thinking is because of the swelling, you get compression on the arterioles, and so you don't have enough vasculature, you don't have enough blood going to the optic nerve. But chronic optic disc swelling will lead to optic nerve atrophy. And the result of that will be decreased acuity, because it's the optic nerve that transmits all those signals to your brain. So we're going to talk about keratitis here, and keratitis is one of the many disorders of the cornea. I divided keratitis as far as infectious keratitis, which we're going to talk about here, from photokeratitis, because photokeratitis is something different. It's caused from UV rays, whereas these forms of keratitis are infectious in nature, and they have a different pathology. So photokeratitis is another disorder of the cornea, but we're going to talk about that separately. And then there's also corneal abrasion, which is very, very common, and then some of these other corneal disorders that we'll talk about later. So the cornea is consistent with the sclera, which is the white of your eye, but the cornea is clear, and that's important because it covers the pupil and the iris, and you have to have something clear covering your pupil if you want light to adequately get into the eye and ultimately reach the retina, which is the goal of having the eye.
I think I overextended this finger.
It's a multi-layered tissue, and it covers the anterior chamber as well as the structures that are in the anterior chambers, namely the iris and the pupil, as well as the anterior ciliary body. So you don't need to be aware of how to read this or look at this. This is step 1 step. You've already done this. However, it's worth remembering that the cornea has multiple different layers. This is stained. This is normally clear. You wouldn't be able to see this. You can't see the cornea in a normal person. These 5 layers are the epithelium, and this epithelium is the outer layer, and this provides your initial layer of
So if you're watching, kindly comment where you're watching from. I just want to know where you're watching from.
Squamous cells at the most outer portion of the epithelium, and that transitions into a more columnar shape. Beneath the epithelium, you have Bowman's layer, which is a tough protective layer, and it also serves as basement membrane for the epithelium. You have a large stromal layer here, and then Descemet's membrane, which serves as a basement membrane for the endothelium. And the endothelium has a pump function, and that pump function helps keep the sclera dry, which is important. And then beneath that, then you have the anterior portion of the aqueous chamber.
Hello guys, if you're watching, kindly comment where you're watching from.
Principles before we start talking about the different forms of keratitis. Number 1, keratitis is an infection of one or many layers of the cornea. So we're going to talk about one type of keratitis, interstitial keratitis, which is only an infection of one layer of the cornea, and that layer is the stroma. However, all the other keratitis, they usually start out on the outside and work their way ulcerating down inward. They cause an ulcer, and that ulcer can be seen when you do a certain test, which we'll talk about in a little bit. Number 2, the symptoms generally include at least redness, mild to moderate pain, photophobia, mild change in vision, which is usually described as blurriness, as well as tearing. And this sets it apart from some of the other things that causes redness of the eye. So when you look at
I hope you guys can hear me.
When you first encounter them, usually an AUD with keratitis, the first thing that you're going to see is their red eye. And red eye has a large differential. So what are some of those things in that differential? First off, conjunctivitis. That would be the most common cause of red eye. However, with conjunctivitis, you don't have a change in vision. You won't have any blurriness. With keratitis, you do have a change in vision. And it's usually described as a mild blurriness. With anterior uveitis, you'll usually have a small pupil, a miosis. With keratitis, the pupil is normal. And then with acute angle closure glaucoma, you're going to have a very severe pain. The patient will rate it as the worst pain they've ever had in their eye. With keratitis, you may have a mild pain, but the patient will probably rate it as a 3, 4, or 5 out of 10. It's more of a...
Hello guys, I hope you guys can hear me.
Body sensation and itchiness, but it's not the worst pain they've ever had before.
If you can hear me, kindly comment where you're watching from.
You'll see an elevated intraocular pressure and then a fixed mid-dilated pupil. With keratitis, there's abnormalities of the eye, but the pupil is not one of them. You should have a normally rated pupil. Number 3, patients who use contact lenses make up the bulk of the patients who present with keratitis. So it's important that you get this in their history if you have a patient with red eyes. The question you should ask, one of the many questions you should ask, is do you wear contact lenses? If the answer to that question is yes, the probability of this being keratitis goes up. These patients are at very increased risk, especially if they don't exercise proper hygiene in handling of their lenses. They're also at increased risk because when they're putting the contact lens in, they are causing a slight trauma to the epithelium, and that increases the risk of infection. And also the fact that they use the contact lens solution that they use, that's just designed to hydrate the contact lens. It doesn't disinfect the lens. And so the lens can grow bacteria, fungus, or protozoa, even though they may clean their contact lens with that solution or clean it with that solution. So in general, having contact lens increases the risk of keratitis for many different reasons. There's other things even further that you can do with contact lenses that make it even worse. If you wear your contacts continuously, you never take them out, that certainly increases your risk. If you swim with your contact lenses in, that's going to increase your risk as well. Number 4, distinguishing the causative pathogen can be difficult. You're not going to necessarily know what the cause is just by looking at the patient's keratitis. So it's going to be important to, well, you're going to want to do two things. One, you're going to want to get a fluorescein stain on them, and then you look with a cobalt blue lamp or with a woods lamp, and that will help you determine whether or not there's
Welcome to my channel, guys.
abrasion there, or abrasion, I suppose that's a differential. But that's going to be one thing that's important to do. And then number two, it's going to be important to get a corneal scraping under anesthesia, because with that scraping, then you can use that to stain or to culture, and that's going to be useful to obtain the correct diagnosis. Number 5, keratitis is vision threatening, and so if you suspect keratitis, it can be very important to get early consultation with ophthalmology. And like I said, ophthalmology, they're going to be the ones who are going to work most of this up. They're going to be the ones who determine the cause, who manage the treatment. But this lecture is
Yeah, I do, Pedro.
an overall idea of what
How are you?
is, how it's treated, so that you have a good grasp on it, so that you don't.
Welcome again to my live.
Okay. So here's our 5 causes of infectious keratitis. We're going to start
How are
with
you?
common, which is bacterial keratitis. We'll also talk about HSV keratitis, which is another very common cause of keratitis, and fungal, interstitial, and acanthamoeba keratitis. These ones are a little less common. Okay, bacterial keratitis is a rapidly progressive.
How was your day?
That is unique to bacterial keratitis. That's very rapidly progresses within 2 to 3 days. Very sight-threatening infection of the cornea involving a bacterial pathogen is mentioned. This is overall the most common form of keratitis. The pathogens here are strep, pseudomonas, gram-negative
Great.
bacteria, and staph. So I would say that strep and pseudomonas are probably the most common. And where do we find pseudomonas? We find it in water. And this
Do you draw too?
starting to come in why contact lenses are a big problem as far as keratitis goes. Risk factors, LASIK surgery. So when you get LASIK surgery done, what are you doing? You're remolding the shape of the cornea.
But then do you post them on your channel?
When you remold the shape, you're causing trauma. So
Do you have a channel?
LASIK surgery, one of the feared complications is bacterial keratitis, which ultimately leads to blindness in some cases. And so like a patient goes in for LASIK surgery, if they're told there's a risk of blindness, there's a risk something could go majorly wrong, bacterial keratitis is, of course, the top of those reasons. Extended wear contact lens use for reasons divulged earlier. The use of
But then do you have an IG?
corticosteroids,
Or you don't post at all?
the immune system. So using it topically will increase the risk of bacterial colonization. Corneal injury, entropion, and chronic dry eye. So symptoms of bacterial keratitis are, as mentioned earlier, you're going to have conjunctival injection, eye redness. That redness is slightly different than the redness that you see with conjunctivitis.
You should start posting.
Have a very generalized redness, and it looks the same anywhere on the
Doesn't matter if your art is not great. I mean, whatever you draw, you should just start posting.
Is generalized, but you see a very circumferential pattern. So the most severe redness is going to be right around the transition from sclera to cornea. So we call this a circumcorneal conjunctival injection.
So you can create a channel on you can create an IG account.
Of course, also you'll have mild changes of vision, pain, photophobia. The cornea may be clear or it may be hazy. The haziness would be caused from the infection. And then you may also note a hypopyon. Hypopyon would be a collection of pus in the anterior chamber. And that would be caused from extension to the anterior chamber, which can happen with keratitis. For diagnosis, because you can't see damage to the cornea, you'll want to use a special dye. And that's
Thank you, Pedro.
And fluorescein staining is done to look for.
I can't wait to see your arts too. So let me know when you create your channel and start posting.
The thing that those two have in common is that they denude the epithelium. So if you were to apply fluorescein to a normal eye and then look at it.
If you have friends too who draw, you can let them
you wouldn't see
watch my channel. Maybe they can learn something from it.
Would just wash wash right off that squamous epithelium. However, if the squamous epithelium is denuded, if it's been scraped off, either due to ulceration from an infectious cause or from
Yeah, good luck
operation,
with that.
then the fluorescein is going to stick to Bowman's layer, that basement membrane, and you're going to be able to see the area where the cornea is damaged. And so I'll show you some pictures of this. Also, in addition, for diagnosis, corneal scrapings should also be performed, and that's for staining and culture. The number one cause of keratitis is bacterial keratitis, but if you give the patient antibiotics and they don't recover, and they don't improve, then we're concerned about a different cause, possibly fungal keratitis, possibly acanthamoebic keratitis. So we're going to want to do these cultures in advance so that we have them as quickly as possible. So this is an example of an ulcer that you can see in bacterial keratitis. So this is this area here where the fluorescein is sticking is the ulcer, and all we mean by ulcer is that the squamous epithelium has been denuded, and so this is the fluorescein sticking to that basement membrane, that Bowman's layer. You have here this whiteness that might be a hypopyon, but I can't tell for sure just by looking at it. And then you can see some. See what might be some haziness in the cornea. That circumcorneal redness, if you note here, you kind of look around the cornea, you see that there's increased redness, especially around, this isn't the best picture of it, but there's a particularly increased amount of neovascularization, your dilation of the vessels. And then this is another bacterial keratitis. Here you just see the infiltrate and then the hypopyon. So what do we do for management? We're going to, of course, first consult ophthalmology. Like I said, they're going to be the ones that primarily treat this. This lecture is just intended to give you an idea of what goes on and how to point this out. Corneal scraping should be sent for analysis, and then the ophthalmologist will start them on broad spectrum antibiotics, particularly that cover Pseudomonas. That's very important. And so what's typically done now, and this is a change from what was done several years ago, is that moxifloxacin is given because moxifloxacin has very good penetration into the cornea, and it's also, as one of those fourth generation fluoroquinolones, it also has good coverage for Pseudomonas. Another regimen that can be used is an alternation of tobramycin and cefazole. Another thing that can be done is a cycloplegic can be administered, and that's for pain. If the ciliary body becomes irritated, you're going to get pain, and so you can administer the cycloplegic.
Hello guys, welcome to my channel. Currently drawing Naruto. If you haven't subscribed yet, kindly do so. It helps a lot. And I hope you like my art.
Corneal thinning, anytime you have an infection, it's going to damage the tissue, and it's going to take time for that tissue to build itself back up to normal thickness. And so you can have corneal thinning. That increases your risk for further infection as well as for perforation. And then perforation is the most feared complication. This typically leads to infection of the inner eye, and this is generally going to destroy the eye itself. So herpes keratitis is the most frequent cause of corneal blindness in the U.S., not the most common cause of keratitis, the most common cause of corneal-caused blindness in the U.S., and it's the most common cause of infectious blindness in the world. This is typically caused by the HSV-1 herpes, so that's non-STD herpes, but it can also be caused by the HSV-2 herpes through contact with genital lesions. Herpes simplex 1 typically will occur in the mucocutaneous distribution of the trigeminal nerve, and so in that manner it can cause keratitis.
Hello guys, where are you watching from?
Going to be the same as keratitis, generalized but highly circumferential conjunctival injection, mild changes in vision, pain, photophobia. So diagnosis, same way you diagnose any keratitis. If you suspect keratitis, you should get a fluorescein staining, and that will help you visualize
okay.
possible
On
lesions.
YouTube or
Now,
Instagram.
with HSV keratitis, this is the one that I want you to know how this appears, because this may be a board question. Wouldn't expect it, but it may be a board question. The lesions associated with HSV keratitis most commonly present in a very characteristic way, and that is in a dendritic.
Alright, great.
That dendritic pattern looks like
I'll subscribe to your channel. Comment it so
that's where the word dendritic comes from, dendros, Latin for
I subscribe to your channel when I'm done.
So most
If
of the
I
time,
don't
it's
remind me,
presented to be in a dendritic pattern. However, very early on,
I'll be your first
you may
subscriber.
notice small vesicular ulcers, and very later on, you may note larger ulcers that kind of look more like what you would see in bacterial keratitis. But the most common way for this to present is when it's in that dendritic stage. The presence of a dendritic lesion is an indication.
Or just comment it now so I subscribe to you with my other channel.
However, you should always get corneal scrapings for staining and culture. So this is a fluorescein stain of a patient with early HSV keratitis. This is primarily what I was referring to as those vesicular, small vesicular lesions. However, you might be able to see kind of some early dendritic pattern in some of these ulcers. Now, this is the dendritic pattern that I was referring to. And if you see this dendritic pattern when you do a fluorescein stain, this is herpes, herpes, herpes. This doesn't appear anything else, not any of the other keratitides. So I would definitely be aware of this. If you're going to take something out of this besides how to your general basic initial management of keratitis, I would take that out of this if you're going to take anything out of these visuals that I've put up. And then this looks more like a plaque. This is certainly HSV keratitis. You can see right here, you got that dendritic pattern down here, but then you have also some plaquing up here. So this is later on in the course. And then this is definitely a plaque here. So much later on. How do we treat this? So of course, number one, if you suspect keratitis and you get a positive fluorescein stain, you're going to consult ophthalmology. You want to get corneal scraping sent out for analysis. We're going to be treating the patient with topical, usually with systemic antivirals. However, that's going to be ultimately at the call of the ophthalmologist. So we're going to be targeting herpes simplex virus. So orally, we can use ganciclovir, famciclovir, acyclovir, and then the ophthalmic preparations are different. I've never heard of topical acyclovir. It might exist, but typically what's used are these drugs that are probably never heard of before, and that's because they're only used with ocular herpes disease. So it only serves one purpose. And those drugs are
You changed the channel name to Logan.
Just like any of the other keratitis.
So comments on my most recent video uploaded, okay?
Spasm, so you can offer cycloplegic for pain, you can also offer NSAIDs, etc. And then antibiotics may be offered. Diagnosis is uncertain. So let's say, for instance, the patient presents like this, and you don't know, it might be HSV keratitis because the patient has a history of herpes, but at the same time, it looks like a plaque, so it might be bacterial. A lot of times with HSV keratitis, the ophthalmologist will also do prophylactic antibiotics, even though they suspect it's herpes keratitis. So that's on the call of the ophthalmologist. You don't need to know whether or not to do that. Complications is corneal perforation. HSV keratitis tends to, as long as it's treated, have a pretty good prognosis. Okay, interstitial keratitis. So this is kind of the black sheep of the family. And this is a site-threatening but non-suppurative inflammation of the stroma. And so up until now, and the next two we're going to talk about after this, these are all suppurative inflammations, or they cause, they're inflammations that cause a
when you do, let me know.
response throughout the cornea. This, on the other hand, is non-suppurative, and it only affects the deep levels of the stroma. It's restricted to the stroma.
No, just comments.
Interstitial keratitis is
Just
almost
open any of my
always the
videos,
cause of syphilis, and particularly
my posted
congenital
videos,
syphilis.
either the live
So this is an
or the
inflammation of the
videos,
stroma, and it causes this
uploaded videos. Just comments.
kind of haziness of the cornea, just like you see in all the other ones. However, as the disease progresses, there is neovascularization of the stroma. And that
Yeah, just anything.
neovascularization, of course,
Say hi.
red, and that redness mixed with the white, inflammation makes for like a pinkish color, and that's a salmon color.
And then when I see it,
it's actually
I'll just check your
called
channel
the,
out.
the salmon patch of Hutchinson. If you remember back to congenital syphilis, you have Hutchinson teeth. It's probably the same guy, I imagine, that named it. So the typical presentation of this is a child, 6 to 12 years of age, with decreased vision, and then this hazy salmon-colored cornea infiltrate. They'll also have pain and photophobia and tearing, like an keratitis. Typically, the condition starts unilaterally, so it only presents in one eye, but ultimately, down the road, either maybe a couple years down the road or a couple decades down the road, they will get infection of the other eye once it's treated. So,
All right.
the history of physical here is going to be really important. You want to know, does the patient have any other signs of congenital syphilis? That should be the first thing you think of if you are suspecting interstitial keratitis. And usually it's
Is it the most recent video?
presents with these symptoms of keratitis, and they have symptoms of congenital syphilis. Therefore, we are thinking this must be interstitial.
Yeah, I just found you.
It can be worked through in many different ways. So, does the patient have any other signs of congenital syphilis? Those can be things like Hutchinson teeth, saber shins, which is just an osteomalacia.
Yeah, I just subscribed.
The shins will.
Can't wait to see your videos.
Saddle nose. That's kind of like if you were to take your nose and press it upward. It kind of looks like that. I don't have any pictures on here of what a saddle nose looks like, but you can Google it. Developmental delay, usually cognitive deficits, deafness, and then seizure disorder.
What's zoomed
all
in?
Signs of congenital syphilis. You also want to know what was the patient's neonatal course. Did they have a rash? Did they have jaundice? Did they have hepatosplenomegaly? These are all early signs of congenital syphilis. And of course, was the mother known to be infected?
You do have one video in your
So
shorts.
this is interstitial keratitis. In this case, you don't see a whole lot of redness, but you do see a salmon color.
Okay, that's nice.
You might not be able to see it really well on the YouTube format, but if you look in on this side, particularly of the infiltrate, you have a much more pinkish, orangish color.
So I subscribe with my other channel, okay?
And then another thing that you will note if you look up closely enough, usually through like a slit lamp, you'll notice.
Because I'm currently on my live.
There's definitely neovascularization here, in addition to the infiltrate. So for diagnosis, you can do a fluorescein stain, and I mean, I would imagine that would be a logical thing to do anytime you suspect keratitis, but if it's performed, you will not note a defect. Why? Because this is not something that affects the epithelium. And in order for a fluorescein stain to be positive, to see an ulcer or an abrasion, you have to have a denudement of the squamous epithelium, because that fluorescein is only going to stick to volume.
Yeah, I did.
In this case,
I commented.
interstitial keratitis, you're only affecting the stroma. The squamous epithelium is
Congratulations.
and so you will not note a defect with fluorescein stain. That sets it apart from all of the other keratitises. Diagnosis should be directed at the underlying etiology that you suspect, which, like I said, is usually syphilis. So you should get a VDRL. If the patient has a positive VDRL, it's worth noting that they should get a CSF analysis for neurosyphilis, which is going to require further management. Treatment is going to be management of the underlying cause. For syphilis, it's going to be penicillin, and then topical corticosteroids can be used here to shorten the disease course once you're treating the underlying cause. Some other causes of interstitial keratitis. Certainly much less common than syphilis, in the US at least, would be TB, leprosy, Lyme's, herpes simplex virus, mumps and measles, acanthamoeba, and then a lot of the tropical parasitic diseases. So those are some of the things that you don't see in the US, like onchocerciasis, leishmaniasis, trypanosoma, like the African sleeping disease.
You're welcome, Pedro. I wish you all the best in your drawing
And then Cogan syndrome.
journey.
Cogan syndrome is a unique one in that this is not necessarily infectious, but it's autoimmune, most likely.
So you can start posting.
This is a triad of interstitial keratitis, as well as the presence of an autoimmune vasculitis condition like Wagner's or PAN, and then also vestibulo-auditory symptoms. So usually the patient will be deaf.
All right, good luck.
Vertigo as well. Like I said, the exact pathogenesis is unknown, but this is Cogan syndrome is a cause of interstitial keratitis. Okay, fungal keratitis is another sight-threatening infection of the cornea, in this case caused by any of a number of species of fungi, and this varies widely based on where you are and what your immune status is. The most common causes are Candida, Aspergillus, and Fusarium. Fusarium was actually linked to a relatively recent contamination of contact lens solution. You need to maintain a high index of suspicion for fungal keratitis, especially in patients who you diagnose with bacterial keratitis, but they don't respond to broad-spectrum antibiotics. And this is a reason why we give those screenings, so that if it happens to be fungal keratitis, then we know sooner rather than later. Risk factors for fungal keratitis include trauma, contact lens use, topical steroid use, surface disease, immunodeficiency, pretty much the same risk factors as for bacterial keratitis. Symptoms here, same for any keratitis: blurred vision, redness, hearing, pain or foreign body sensation, photophobia, possibly discharge, corneal infiltrate. For diagnosis, pretty much the same thing here. Fluorescent visualization should be performed. The ulcers are remarkably similar to bacterial keratitis. There's a few differences, but it's difficult to distinguish this from bacterial keratitis just on face value. The lesions can be a little less distinguishable. They might have more fuzzy borders rather than really delineated borders. But other than that, it's very difficult to determine the two apart from one another. Corneal scrapings, again, like I mentioned, are going to be of the utmost importance for staining and culture. So, here's just an example of fungal keratitis. This is affecting the epithelium as well as Bowman's layer stroma. So here's an infiltrate. Here's an example, a better example of that circumcorneal redness. You can see more towards the periphery, you have a little bit more white here, but there's much more redness coming in along the periphery of the cornea. So one of the differences from conjunctivitis. You can see it here too, a little bit whiter around the sides here, and then some redness around the cornea. And here's your different from your bacterial. Don't worry about determining, just looking at the infiltrates. As far as USMLE is concerned, as far as practice is concerned, that's the ophthalmologist's job. The one I do want you to remember, though, is the herpes virus. Okay, so differential. On finding a corneal ulcer, you should always consider the other causes of keratitis. So herpes should be considered, especially in patients with prior herpes virus infections or a previous diagnosis. Acanthamoeba keratitis, which we'll talk about next, should be considered especially in patients with a history of...
So I'm just smudging all this, trying to blend it out, because skin is not.
As far as treatment here, we're pretty much doing the
just
same
adding
thing.
value to all this.
Ophthalmology consult, corneal scrapings, sent for analysis. Topical and
See how it looks?
systemic antifungals are used here.
After I just smudge the pencil all over.
Ophthalmically, nanomycin is a common one that's used. And then for pain, you can use cycloplegics, NSAIDs, And broad spectrum antibiotics are usually offered depending on what the ophthalmologist determines. A big reason why you may want to use broad spectrum antibiotics is because of difficulty in differentiating fungal from bacterial keratitis. But another good reason is because about 20% of fungal keratitis cases will develop a bacterial superinfection. And so you don't want to have that co-infection along with fungal keratitis. It will just complicate things more. So a lot of times the ophthalmologist will give both antifungal regimen and an antibiotic regimen. Complications include corneal perforation and bacterial co-infection, as mentioned. And because of the difficulty in getting
I had a patient with corneal perforation today.
Before it's
It was crazy.
And so this is associated with severe visual loss in anywhere between 26 and 63% of patients.
And sad at the same time.
And finally, acanthamoeba keratitis. This is a rare vision-threatening amoebic infection seen most frequently in contact lens wearers, especially those who swim with their lenses in and fail to exercise adequate hygiene with lenses. So in a vignette, think of a 16-year-old who went swimming in a lake with their contact lenses in, and a few days later has all the signs of keratitis. Here you're thinking acanthamoeba keratitis. So this has also been associated with contaminated contact lens solution, and the risk factors is primarily.
I think I'm gonna stop now.
80% of patients, so only 20% of patients with acanthamoeba.
And then give it a background tomorrow.
The symptoms here are the same as any keratitis: the blurry vision, the redness, the
First time drawing Naruto.
hearing discharge, possibly corneal infiltrates may be seen. Acanthamoeba infection can also cause anterior uveitis as well as hypopyon if it extends to the anterior chamber, and it can also cause scleritis. The symptoms here tend to be mild early on, but without treatment, it's going to progress to total visual loss.
Forgot to do this.
A lot of times, this is not diagnosed until it's too late. The diagnosis here, again, you can do fluorescein staining, get corneal scrapings. Corneal biopsy can be useful if the corneal scrapings don't show you any useful reasons. This is an example of acanthamoeba keratitis. Don't worry about how to tell this just by looking at it. The treatment here is pretty much the same as usual, except we want to focus on the acanthamoeba. So the treatment, you will not get asked that on the USMLE. The reason is because the exact regimen that should be used is controversial and there's no broad consensus. However, very commonly PO voriconazole or ketoconazole is used, as well as topical ophthalmic treatment. The complication is corneal perforation as well as co-infection, and like I said, this typically has a poor prognosis. Okay, finally, I just want to bring up a note here that a key differential for any corneal ulcer or keratitis is a corneal abrasion, and vice versa. When you think about a corneal abrasion, which is a really common thing to happen, that a patient can come into the clinic or into the ER, you also want to think of possibly keratitis. So, what do these have in common? First, they look the same. As far as they both cause a certain level of pain or a foreign body sensation, they can cause blurry vision, photophobia. So we're thinking corneal ulcer or corneal abrasion. Also, if you stain the patient's eye with fluorescein, they're going to look pretty similar, because even though with corneal ulcer it's affecting much deeper, with a corneal abrasion, you've abraded, for lack of a better word, enough of the epithelium off to where you're still going to get a positive fluorescein stain. All you need to do is denude off enough of the epithelium and you'll have a positive fluorescein stain, regardless of what caused it. So they look similar in those two ways. But how do we tell them apart? A corneal abrasion is associated with really recent mechanical trauma. So usually the patient will say something like, I was putting my contacts in and my fingernail slipped and scratched my eye, A lot of times the patient will be able to relate this to you. And this is typically, the symptoms will come on within hours of the trauma. And it's very, very annoying to the patient. And so if they come in, we'll usually be able to
Okay,
recall
guys, thank you
when
so
these
much for
symptoms.
watching.
The corneal
See you
lesions will never
tomorrow,
present with infiltrates, so if they
same
have any kind
time.
of haziness
Bye.